So I think that when we are speaking about young patients, the goal in the future, the aim will be to cure, in fact, some of them. But when speaking about cure, we have to keep in mind some very important numbers, in fact. So what is the residual life expectancy at the age of 65? This is an Australian database. In patients at the age of 65, you have 22 years of life expectancy. This is exactly the same in the US, in fact. At 65 years, you can live 20 additional years. So when treating a young patient with stem cell transplantation, we can think of curing patients when they will be alive at the age of 85. So this is the goal. And I think that frontline stem cell transplantation is remaining the standard of care for our patients. And this is based on this IFM-DFCI study. You know that we have randomized 8 cycles of RVD versus RVD plus stem cell transplantation up front with the same duration of maintenance, 1 year in both arms. We have enrolled 700 patients in that study, and the results were presented at the last ASH meeting by Michel Attal, and we are clearly showing that the progression-free survival is highly increased with the use of a systematic upfront stem cell transplantation in the context of a triplet induction regimen. And you can see that all subgroups of patients are benefiting for high-dose treatment in this study, ISS1, 203, standard or high-risk cytogenetics, etc. So standard of care, to our opinion, is stem cell transplantation upfront. And at the next ASCO meeting in 5 weeks from now, Michele Cavo will report on the very first results of this very important EMN study, comparing as well 4 cycles of VTD and no stem cell transplantation upfront with VMP versus VCD and or either a single or a tandem stem cell transplantation. And he will show that stem cell transplantation is also associated with a better PFS. So we'll have the confirmation of the IFM-DFCI study showing that we need to perform stem cell transplantation up front. So the goal is to achieve the best response, if possible, and also to have sustained response. And this concept was introduced by Bart quite a long time ago. So this is the proposal of frontline treatment that we can apply to patients that are eligible for stem cell transplantation. A triplet induction, stem cell transplantation, consolidation and maintenance, and this is probably the optimal strategy for our patients. So what about induction? We know that the achievement of a very good response following induction is a very important prognostic factor for progression-free survival. In the Italian study, in the French study, reaching a very good response, VGPR or a near-CR, was associated with a better outcome. And this prognostic factor was more important as compared with cytogenetics and also as compared with ISS. So we do have a number of triplet regimens that are proposed, in fact, in the guidelines, both in the US and in Europe. But we have very few phase 3 comparison, in fact. So the first study comparing VCD versus PAD, bortezomib dex induction plus either cyclophosphamide or doxorubicin, was reported last year by the German group, a very large number of patients, more than 500 patients, 3 cycles of VCD versus 3 cycles of PAD. And you can immediately see that both regimens are equally effective in terms of response. VGPR rate were identical in both arms of the study, but VCD was considered as being less toxic with a less severe adverse event as compared with PAD. So according to this German study, we should use VCD. In France, we have tested the prospective comparison of VTD versus VCD, and these 2 regimens are the most widely used in Europe. VCD 4 cycles versus VTD 4 cycles on a very large number of patients. The primary endpoint was VGPR achievement, and we showed that VTD was associated with a better VGPR rate as compared with VCD following a centralized analysis of the response. But the hematologic toxicity was higher in the VTD arm, grade 3 or 4, but on the opposite, the peripheral neuropathy rate and grade 3 or more, and also grade 2 or more, was better in the VCD arm as expected, and VTD was associated with a higher rate of peripheral neuropathy. So this is the experience of the French IFM study. We did quite a lot of randomized prospective study comparing VAD versus Veldex, Veldex versus VTD, VTD versus VCD, and overall you can see an improvement over time of the VGPR rate with VAD, with Veldex, and with the triplet VTD, VCD, and now the recent results of RVD presented by Michel et al. At ASH. So what we can say is that we need to use a triplet regimen, and probably in the future, based on the very good tolerability of the VRD regimen, VRD will become the backbone probably in the future in our trials. So it is important to achieve a good response following induction, but also a good response following stem cell transplantation. And the achievement of stringent CR was reported by the group of the Mayo Clinic 2 years ago as a very important endpoint as well. They looked at 445 consecutive patients treated with stem cell transplantation, and 25% of them were able to reach stringent CR. When you're looking at overall survival, CR or better, of course, patients having a good overall survival as compared with less than CR. But when comparing stringent CR versus conventional CR, you can see that stringent CR is associated with a better overall survival. And the concept of a sustained stringent CR is also very important. In these two landmark analyses, you can see that sustained stringent CR is associated with a better overall survival. So the concept is to reach the best response and to have a sustained response with the use of consolidation first to improve the depth of the response. And Paul will show you some data on consolidation following my talk. The concept was introduced by Antonio and the group of Torino. They proposed 4 cycles of VTD following stem cell transplantation quite a long time ago, and the study was recently updated in leukemia. And you can see that patients that were able to reach molecular CR following VTD were enjoying a better outcome as compared with patients not achieving major MRD negativity. The concept of sustained CR is also relying on maintenance following consolidation. And Paul will present you some data on maintenance. And we know that with lenalidomide maintenance following stem cell transplantation, as reported in this CALGB study, len maintenance versus no maintenance, the overall survival is improved. And at the next ASCO meeting as well, Michel et al. Will present a very important meta-analysis of len maintenance versus no maintenance on a very large number of patients on individual patient data, and showing an overall survival benefit with lenalidomide. So I encourage you to go to Chicago to listen to this important presentation. So this is what we are calling within IFM the optimal strategy: a good induction, stem cell transplantation, short-term consolidation, and short-term maintenance. And the 5-year survival rate was very high, and that was the basis of our randomized IFM 2009 study. And I showed you previously the PFS benefit. And this is the overall survival of our patients treated into that protocol. So the survival is very, very good, but how many patients are cured? That we don't know exactly. And we need to improve on these results. So how to improve? We have to work on induction first. I showed you that induction is a very important part of the study. And over time we have improved induction, and probably one of the best regimen is not VRD or VTD, is probably KRD. So do we have data supporting KRD? Some data were reported recently by the group of New York in the JAMA Oncology with a very good PFS with KRD alone, without stem cell transplantation. KRD is also tested in a very important study coming from Italy, chaired by Antonio and Michele Cavo, in fact comparing KRD versus cyclocarfildex with or without stem cell transplantation. And Dr. Jakubowiak in Chicago was one of the first to introduce KRD as well in the US. And he reported 2 consecutive phase 2 trials, KRD without stem cell transplantation and KRD with stem cell transplantation. This is not randomized, 2 phase 2 consecutively performed trials. And what is the outcome, in fact? This slide is a very recent one. You can see with KRD without stem cell transplantation, the PFS is good. But with KRD plus stem cell transplantation, the results are outstanding, to my opinion. You can see the PFS, although the number of patients is rather small, although the follow-up is short as well. But nevertheless, these results are very encouraging. So KRD plus stem cell transplantation is probably very interesting. How to improve induction? Maybe we can use RVD as a backbone and add a monoclonal antibody. This is a German randomized study, induction with RVD plus or minus ELO, followed by stem cell transplantation. This study is ongoing in Germany. In IFM and in the Netherlands, we are running this VTD plus or minus DARA. So monoclonal antibodies, either ELO or DARA, maybe will be able to use to increase the response rate at the time of induction. Can we also improve the conditioning regimen and this very important phase of stem cell transplantation by itself? This is what we are doing in routine. MEL 200 in France and 2 cycles of VTD consolidation. And we are currently running a randomized study comparing MEL 200 versus MEL 200 plus bortezomib for infusions of bortezomib 2 prior and 2 following stem cell transplantation. We have enrolled almost 300 patients in that study, and you will be able to have the results next year. And the PI is Michel Attal in Toulouse. So we can also work on consolidation in order to improve the response rate once again. And this is a study that is currently running in the US, comparing following a first stem cell transplantation, either VRD, consolidation, or a second stem cell transplantation. And we know that tandem could be important, especially in the context of high-risk cytogenetics. And in the EMN2 study, there is also a very important question comparing 1 versus 2 stem cell transplantation. I don't know if Michele will be able to show some results on 1 versus 2, probably not, but we have to await for these very important results as well. The consolidation, we can also use ELO, RVD consolidation plus or minus ELO. This is once again the German study. We can also use, of course, daratumumab, and in the French and the Netherlands study, we are going to compare VTD consolidation plus or minus DARA. So many options, in fact, tandem stem cell transplantation, monoclonal antibodies as well. And we can try to improve as well the maintenance phase. So what are we doing? Single agent. We are doing also DARA versus no DARA maintenance during 2 years in this study in Cassiope. There is also an ongoing study, phase 3, comparing IXA versus placebo following stem cell transplantation. We are enrolling patients into that study as well. Antonio is looking at LEN maintenance that will probably become the standard of care in the future versus LEN plus Carfil in the Italian study. And ELO is also tested with Lendex as a maintenance versus Lendex plus ELO. So plenty of possibilities with the aim of improving the quality of response, improving the duration of the response as well. But we need to monitor carefully. Bart mentioned too many trials. you should go and look at MRD. And this is very important. We should monitor systematically MRD in the context of stem cell transplantation, to my opinion. And what are the techniques that are available to monitor MRD in myeloma? We have two techniques to look at the disease within the bone marrow: 8-color flow cytometry, next generation flow, and there is a big US and European effort to standardize the CMF technology, but also we can use NGS within the bone marrow. And outside the bone marrow, we can look at PET-CT to evaluate minimal residual disease. Hervé Avelloiseau looked at the patients treated with stem cell transplantation, or RVD, in the IFM 2009 study, and he showed that with flow cytometry, 7-color flow in that study, we were able, according to MRD negativity, to segregate two groups of patients with a different outcome. So MRD negativity can be evaluated by flow. It can be also evaluated by NGS, as I mentioned previously, and in the same trial we looked at NGS, and Hervé was able to demonstrate that this cutoff, 10-6, was the best one to segregate two different groups of patients with a very, very different outcome. We also looked at the impact of PET-CT to monitor patients following stem cell transplantation before maintenance. And when patients are reaching PET negativity, the PFS is highly improved versus PET positivity before maintenance in this IFM 2009 study. And we had some patients that could be evaluated both for PET and for flow cytometry, either negativity, positivity, etc. And you can see that we do have some patients that are both PET negative and flow negative. We are calling these patients double negative, PET and MRD within the bone marrow, and these patients are representing almost 50% of the total group. But these two tests are totally complementary. We do have some patients PET negative and MRD positive. We do have some patients positive for PET and negative for flow. So we need to do these two complementary tools to evaluate MRD within and outside the bone marrow. And when you are looking at the outcome of patients double negative, PET and flow negative, versus those with either PET or both, or flow or both techniques positive, the outcome is totally different. And at 3 years, you have almost 90% of the patients that are PFS with a very, very good PFS without any relapse when they are reaching PET and MRD negativity by flow. So we can probably use in the future high-dose treatment with a very good induction, good consolidation, short maintenance, and raised some important issues, some important questions according to PET negativity, NGS negativity. Do we have to use a long maintenance phase? What is the optimal of maintenance? LEN will be the backbone, but are we going to use ICSA, DARA, or ELO combinations? And importantly, what is the optimal duration? If we need to think of curing patients, we need to have a fixed duration of treatment. Treatment until progression is not cure, to my opinion. And we can randomize patients to short maintenance versus no maintenance, for example. So my conclusions are the following. For young patients, we have to increase the quality of the response, work on induction, work on consolidation and maintenance. We have to evaluate MRD. We have to define the optimal maintenance and its duration. I didn't have time enough to speak about understanding chemoresistance and myeloma diversity, because probably we have to adapt the strategy according to risk factors clearly defined at the time of diagnosis. And I thank you for your attention.